All right, let's talk about a classic OSCE station, one that every single trainee is going to face: palpitations. Now, this is a tricky one, right? Because it can be something totally harmless, or it could be a sign of something life-threatening. The goal here isn't to turn you into a cardiologist overnight, no. It's to make sure you can show that examiner a safe, systematic approach when you're under pressure. Okay, let's get into it.
So, you walk into the room, and this is what you see on the paper. Miss Tan, 30, a teacher, worried about a racing heartbeat. You've got 8 minutes. The clock is already ticking. For the next 8 minutes, this piece of paper is your entire world. The key, and I mean the absolute key, is to have a mental game plan locked and loaded before you even say a word to the patient.
And this is that game plan. It's 3 simple steps. Number 1, safety first. Are there any red flags screaming at you that this person needs to be sent to the hospital right now? 2, you're going to use a sieve. You're sorting through all the possibilities. Is this coming from the heart or is it something else? Anxiety, too much coffee, a thyroid problem. And 3, you've got to assess their risk. What's their background? What's their family history? Think of this framework as your anchor. It's going to keep you calm and structured so you don't panic and forget something crucial.
Okay, let's build on that foundation, the history. This is where you are going to score the bulk of your marks, so let's make sure we get the structure absolutely perfect.
First things first, you've got to get the patient to describe what this palpitation actually feels like. Don't just accept the word. Dig a little deeper. Ask them, what do you mean by that? Is it a fast racing, a fluttering, like a butterfly on the chest? Or does it feel like your heart is skipping a beat and then giving a big thud? The words they use are your first big clues. That skip beat followed by a thud sensation, that often points to benign ectopic beats.
Now, here is an absolute golden nugget for your OSCE. This question is fantastic, it's practical, it's engaging, and it gives you a ton of information. If they start tapping out a really irregular, chaotic beat, well, your mind should immediately be thinking atrial fibrillation. But what if they tap out a super fast, perfectly regular, galloping rhythm? Now you're thinking more along the lines of a tachyarrhythmia, maybe something like an SVT. This one little action can tell you more than a whole paragraph of description. It's like getting a real-time rhythm strip right there in the room.
Next up, you have to nail down the timing. Ask about the onset. Was it sudden? Like someone just flipped a switch? That really points towards an arrhythmia. Or did it kind of build up slowly? That's more typical for something like anxiety. And how long does it last? If the episodes are just a few seconds, it makes a serious cardiac cause a bit less likely. And of course, the triggers. What brings it on? Is it when you're running for a bus, when you're stressed at work, or does it just happen out of the blue?
Okay, now for the really important stuff. The associated symptoms. These are your early warning signs. Of course, you're going to ask about the obvious ones: chest pain, shortness of breath, dizziness. But don't just stop there. You have to ask about pre-syncope, that feeling of almost passing out. And here's a subtle one that will really make you stand out. Ask about polyuria, the need to pee a lot right after an episode. That is a classic clue for an arrhythmia that starts in the atria, like SVT. It's all because the stretched atria release a hormone that makes you need to go.
Right, let's zoom out a bit now and look at their baseline risk. Do they already have known heart problems, high blood pressure, diabetes? And then you have to ask the critical family history question. Specifically, you need to ask if any family members died suddenly and unexpectedly, especially if they were young, under the age of 40. A yes to that question is a massive red flag for inherited conditions, things like long QT syndrome. You can't miss this one.
And finally, for the history, we have to talk about triggers. And listen, it is not enough to ask, do you drink coffee? That's a rookie mistake. You have to quantify it. How many cups a day? Are we talking espressos or filter coffee? Same goes for alcohol, for nicotine. You need numbers. And don't forget to ask about over-the-counter stuff. Nasal decongestants are a common culprit. And of course, they're prescribed meds, like asthma inhalers. And yeah, in the right situation, you have to sensitively ask about illicit drug use. Okay, let's move on to the most important part of this whole talk, the critical red flags. Seriously, if you take away only one thing from this whole explainer, make it this, because missing one of these is a straight-up fail. This is all about being a safe doctor. This slide lays it all out for you. Syncope, actually fainting or losing consciousness during an episode, is the single highest risk symptom. You have to ask about it directly. Chest pain or severe breathlessness tells you the heart muscle itself is in distress. Palpitations that start during physical activity are way more worrying than ones that happen when you're just sitting around. And we've already covered that crucial family history question. My advice: learn these questions word for word.
Right, you've got your history, you've screened for red flags. Now it's time to start putting those puzzle pieces together and forming your list of possible diagnoses.
Now, take a look at this. It's kind of interesting, right? In primary care, psychosomatic causes, anxiety, panic, they make up the biggest slice of the pie, nearly a third of cases. So yeah, anxiety is common. But let me be really clear. Your job in the OSCE is not to spot the most common cause. Your job is to safely rule out the most dangerous ones first, like AFib and SVT. This chart just helps you keep things in perspective.
Let's talk about the traps, the common mistakes that I see trainees make all the time. First, asking about dizziness is not the same as asking about fainting. It's not specific enough. You lose marks for that. Second, and I know I sound like a broken record, but you have to quantify lifestyle stuff. A simple yes to coffee tells the examiner nothing. And third, and this is a big one, never, ever jump to the conclusion that it's just anxiety without doing your homework first. Remember, a serious cardiac problem can absolutely coexist with anxiety.
Okay, so you've wrapped up your history. Now you have to pivot smoothly and tell the examiner exactly what you would do next. It's time for your examination and initial plan. And your plan can be broken down into 3 super clear parts. 1, a focused examination. You're going to check their pulse for rate and rhythm. You'll do a blood pressure, including orthostatics. You'll listen to the heart, and you'll look for any clues of things like anemia or thyroid disease. 2, investigations. A 12-lead ECG is absolutely mandatory. You can't not say that. And you'll want some baseline blood tests. And 3, you triage. If you found any red flags, that patient needs an urgent referral, period. If not, you can start the investigations and give some initial advice about common triggers like caffeine.
All right, let's get to the good stuff. The perfect OSCE summary. This is all about bringing it home, tying everything together with some polished phrases that will make you sound confident and structured, even when your heart is pounding. Here is your opening line. It's perfect. It's empathetic. That sounds worrying. It sets the agenda for the consultation, and it asks for permission. Is that okay? Right from the first second, it shows the examiner that you are professional and patient-centered. Get this structure down. Make it your own. It's a brilliant way to start. Now, safety netting. This is absolutely non-negotiable. You have to do it, and you have to do it well. This script here is clear, it's specific, it uses those exact red flag symptoms we talked about, and, crucially, it closes the loop by checking for understanding. That little phrase, "do you have any questions about that?" is so important. And finally, this is how you summarize everything for the examiner at the end. It's a simple checklist. You start with your main concern. You give them a quick summary of the key things you found, and what you didn't find, especially the red flags. You offer 2 or 3 likely diagnoses, you state your clear plan, exam, ECG, bloods. And you finish by stating that you've given clear safety netting advice. Follow the structure and you will score very highly. Okay, so there you have it, a clear, repeatable system for acing the palpitation station. Before you go, let's do a quick knowledge check. Pause this and really test yourself. Can you name 3 of those critical red flags? What are the 3 essential first-line tests you're going to order? And what's the most common cause you'll see in the clinic? If you can nail those questions, you've built a really solid foundation. Remember, it's not about being a cardiologist, it's about being a safe, systematic doctor. Thanks for watching. Good luck in your exams.